Diseases of the breast. Q&A. Welcome to today's podcast, where we discuss the main aspects of diseases of the breast. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of diseases of the breast. Pause the podcast after each question to attempt answer. Let's begin. Epidemiology of breast cancer. Question: what is the global prevalence of breast cancer? Answer: breast cancer is the most prevalent cancer worldwide, with more than 2 million cases and 685,000 deaths reported each year. Question: what is the mortality ranking of breast cancer among cancer-related deaths in females in the United States? Answer: breast cancer is the second leading cause of cancer-related deaths in females in the United States, with an estimated 43,700 deaths in the year 2023. Question: how have 5-year survival rates for breast cancer changed in recent years? Answer: 5-year survival rates for breast cancer have steadily improved, reaching 91% during the period from 2012 to 2018. Question: how do global incidence and mortality rates of breast cancer differ by region? Answer: incidence rates of breast cancer are higher in developed regions, whereas mortality rates are elevated in regions with limited access to healthcare. Question: what are the racial and ethnic disparities in breast cancer incidence and mortality in the United States? Answer: in the United States, white females have the highest incidence of breast cancer, while black females experience the highest mortality rate. This is partly due to a higher incidence of triple-negative breast cancer and later stage diagnosis among black females. Question: what factors influence variations in breast cancer incidence and mortality? Answer: variations in breast cancer incidence and mortality are influenced by reproductive, hormonal, and behavioral risk factors, as well as the presence of screening programs and access to healthcare. Pathology of breast cancer. Non-invasive, in situ breast cancer. Question: how is lobular carcinoma in situ classified, and what is its significance regarding breast cancer risk? Answer: lobular carcinoma in situ is no longer considered a neoplasm but rather a risk factor for breast cancer, and pleomorphic lobular carcinoma in situ is a more aggressive subtype. Question: what is the morphology of ductal carcinoma in situ and how does it compare to lobular carcinoma in situ? Answer: ductal carcinoma in situ is more heterogeneous than lobular carcinoma in situ, with 5 main types including micropapillary, papillary, cribriform, solid, and comedo, and it often exhibits mixed morphology. Question: which factors are most important for the prognosis and treatment of ductal carcinoma in situ? Answer: grade and estrogen receptor status are more important than architectural pattern for prognosis and treatment of ductal carcinoma in situ. Question: can ductal carcinoma in situ progress to invasive cancer and how does its morphology relate to the invasive form? Answer: ductal carcinoma in situ can progress to invasive cancer, often mirroring the morphology of the original ductal carcinoma in situ cells. Question: what type of calcifications are indicative of ductal carcinoma in situ on mammography? Answer: microcalcifications on mammography, ranging from tiny, pleomorphic forms to segmental patterns, are indicative of ductal carcinoma in situ. Question: how often do ductal carcinoma in situ and invasive cancers coexist, and what is their relationship in terms of morphology? Answer: ductal carcinoma in situ frequently coexists with invasive cancers, and they often share similar morphological characteristics. Invasive breast cancer. Question: what are the 2 main types of invasive breast cancer? Answer: invasive ductal carcinoma and invasive lobular carcinoma are the 2 main types of invasive breast cancer. Question: what are the characteristics of invasive ductal carcinoma? Answer: invasive ductal carcinoma is the most common type, accounting for 50 to 70% of cases, grows as a cohesive mass, and is often palpable and detectable on mammograms. Question: what are the characteristics of invasive lobular carcinoma? Answer: invasive lobular carcinoma is less common, comprising 5 to 15% of cases, infiltrates in a single file pattern, and is often clinically occult and difficult to detect. Question: what are the characteristics of medullary carcinoma? Answer: medullary carcinoma is high grade, has numerous mitoses, lacks an in situ component, forms sheets of cells, and is surrounded by a lymphocyte infiltrate. Question: what are the characteristics of metaplastic carcinoma? Answer: metaplastic carcinoma is high grade, negative for estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2, has a high metastatic potential, and is associated with a poor prognosis. Question: how is tumor grading determined in breast cancer? Answer: tumor grading in breast cancer is based on the Nottingham histologic score, which considers glandular or tubular structures, nuclear pleomorphism, and mitotic rate to determine tumor grade from 1 to 3. Molecular markers. Question: which molecular markers are routinely tested on breast cancer specimens at diagnosis? Answer: estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2 are routinely tested on breast cancer specimens at diagnosis. Question: how do estrogen and progesterone receptor status affect the benefit from adjuvant endocrine therapy? Answer: estrogen receptor and progesterone receptor status predict which patients may benefit from adjuvant endocrine therapy. Question: what is the significance of human epidermal growth factor receptor 2 overexpression in breast cancer? Answer: human epidermal growth factor receptor 2 protein overexpression, found in approximately 20% of breast cancers, is measured by immunohistochemistry and scored from 0 to 3. Question: how is human epidermal growth factor receptor 2 status determined and what therapies does it predict response to? Answer: human epidermal growth factor receptor 2 status is determined by immunohistochemistry and in situ hybridization, and it predicts response to human epidermal growth factor receptor 2 targeted therapies such as trastuzumab and pertuzumab. Question: what does Ki67 expression indicate in breast cancer? Answer: Ki67 expression, assessed as a percentage of positive nuclei, indicates tumor cell proliferation and growth in breast cancer. Question: how is breast cancer classified and what makes it a heterogeneous disease? Answer: breast cancer is classified based on estrogen receptor, progesterone progesterone receptor, human epidermal growth factor receptor 2, and Ki67 status, as well as gene expression profiling, making it a heterogeneous disease with varying behavior. Question: what are the four main subtypes of breast cancer, and what are their characteristics? Answer: the four main subtypes of breast cancer are Luminal A, Luminal B, human epidermal growth factor receptor 2 enriched, and Basal-like, each with distinct characteristics. Question: what are the features of Basal-like breast tumors? Answer: Basal-like breast tumors are often triple negative for estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2, and are associated with BRCA1 mutations. Question: what prognostic information do genomic assays provide for breast cancer? Answer: genomic assays such as the 21 gene recurrence score assay provide prognostic information by analyzing gene expression in tumor samples. Question: which genomic assays are used to determine prognosis and guide treatment decisions in breast cancer? Answer: MammaPrint, PAM50, EndoPredict, and Breast Cancer Index are genomic assays used to determine prognosis and guide treatment decisions in breast cancer. Question: how does the MammaPrint assay classify breast cancer risk? Answer: the MammaPrint assay analyzes data from 70 genes to provide a low-risk or high-risk readout for estrogen receptor-positive or estrogen receptor-negative tumors. Question: what is the purpose of the Oncotype DX assay and other multi-gene assays in breast cancer? Answer: the Oncotype DX assay and other multi-gene assays are used to assess the benefit of adding chemotherapy to endocrine therapy in early-stage breast cancer. Other tumors of the breast: Phyllodes tumors. Question: what are Phyllodes tumors and what is their composition? Answer: Phyllodes tumors are uncommon breast tumors with a mix of connective tissue and epithelium, and they range from benign to malignant forms. Question: what are the characteristics of Phyllodes tumors? Answer: Phyllodes tumors are firm, lobulated masses, typically larger than 3 centimeters, with a history of rapid growth, and they rarely metastasize to lymph nodes. Question: how are Phyllodes tumors diagnosed and classified? Answer: Phyllodes tumors are confirmed through core needle biopsy or excisional biopsy, and then classified as benign, borderline, or malignant based on stromal features. Question: what is the treatment for Phyllodes tumors? Answer: benign Phyllodes tumors are treated with excision, while intermediate and malignant Phyllodes tumors require wide excision with negative margins. Question: when is mastectomy considered in Phyllodes tumors? Answer: large Phyllodes tumors may necessitate a total mastectomy. Question: why is close follow-up important in patients with Phyllodes tumors, and how are metastases treated? Answer: close follow-up is crucial due to the risk of local recurrence, and metastases, primarily to the lungs, are treated with chemotherapy. Angiosarcoma. Question: what is angiosarcoma of the breast, and how is it classified? Answer: angiosarcoma is a rare vascular tumor, accounting for 1% of all breast tumors, and can be primary, originating in the breast, or secondary, developing in the skin after irradiation. Question: what is Stewart-Reeves syndrome and when does it typically occur? Answer: Stewart-Reeves syndrome is a type of secondary angiosarcoma that occurs in the upper extremity of patients with lymphedema, typically 10 to 15 years after radical mastectomy and irradiation. Question: what is the primary treatment modality for angiosarcoma of the breast and why? Answer: surgery is the primary treatment modality for angiosarcoma of the breast, aiming for negative margins to improve long-term outcomes, and adjuvant irradiation is often recommended due to the high risk of local recurrence. Question: when is neoadjuvant or adjuvant chemotherapy considered for angiosarcoma? Answer: neoadjuvant or adjuvant chemotherapy is considered for high-risk angiosarcoma tumors based on differentiation, size over 3 to 5 centimeters, and spread. Question: how does metastatic spread occur in angiosarcoma of the breast, and which organs are most commonly affected? Answer: metastatic spread in angiosarcoma of the breast occurs through the blood, most commonly to the lungs and bone, and less frequently to the abdominal viscera, brain, and contralateral breast. Question: what factors influence outcomes in angiosarcoma of the breast, and what is the range of 10-year survival? Answer: outcomes in angiosarcoma of the breast are based on grade and size, with 10-year survival ranging from 28% to 82%. Staging of breast cancer and treatment planning. Question: what system is used to stage breast cancer and how does it guide treatment? Answer: the American Joint Committee on Cancer Tumor Node Metastasis Classification System is used to stage breast cancer, and it groups patients by risk category to guide treatment. Question: what does the Tumor Node Metastasis Classification System consider in staging breast cancer? Answer: the Tumor Node Metastasis Classification System considers tumor size and extent, lymph node involvement, and distant metastases. Question: what additional factors are incorporated in the 8th edition of the American Joint Committee on Cancer System for breast cancer staging? Answer: the 8th edition of the American Joint Committee on Cancer System incorporates tumor grade, biomarkers such as estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2, genomic assays, and neoadjuvant treatment response. Question: how are clinical stage II and pathologic stage IA defined in breast cancer after neoadjuvant therapy and surgery? Answer: clinical stage II is defined as clinical tumor size 2, clinical node 1, clinical metastasis 0, and pathologic stage IA is defined as pathologic tumor 0, pathologic node 1, metastasis 0 after neoadjuvant therapy and surgery. Question: what are the main treatment modalities for breast cancer and what factors are considered? Answer: the main treatment modalities for breast cancer are surgery, including therapeutic and reconstructive procedures, radiation therapy, and systemic therapy, with consideration of patient and tumor characteristics. Question: why is a multidisciplinary approach essential in breast cancer treatment planning? Answer: a multidisciplinary approach is essential for optimal patient-centered treatment planning because it considers the interplay between surgical, medical, and radiation oncology decisions. Question: when are imaging studies such as computed tomography scans and bone scans used in breast cancer patients? Answer: computed tomography scans, bone scans, and other imaging studies are generally reserved for patients with clinically positive nodes, abnormalities on blood chemistry tests or chest radiographs, and symptoms based on history and physical examination. Question: what is the role of surgery in the treatment of breast cancer without distant metastatic disease? Answer: in the absence of distant metastatic disease, surgery is a central part of breast cancer treatment. Question: which patients with breast cancer should receive neoadjuvant systemic therapy before surgery? surgery? Answer. Patients with locally advanced disease and inflammatory breast cancer should receive neoadjuvant systemic therapy before surgery. Surgical treatment of breast cancer. Question. Why is surgery important in the management of locoregional breast cancer? Answer. Surgery is crucial for diagnosing, treating, staging, and assessing response to treatment in locoregional breast cancer. Question. What factors influence the selection of a surgical procedure for breast cancer? Answer. Factors such as patient characteristics, tumor location and size, and patient preferences influence the choice of surgical procedures. Question. Why is a multidisciplinary approach essential in breast cancer surgery? Answer. A multidisciplinary approach is essential because each treatment modality, including surgery, systemic therapy, and radiation, impacts the others. Historical perspective. Question. What did the early treatment for breast cancer involve? Answer. Radical mastectomy, introduced in the 1880s, involved removing the breast, skin, pectoralis muscles, and axillary lymph nodes. Question. What was the rationale behind performing a radical mastectomy? Answer. This procedure was based on the belief that breast cancer spread primarily through local extension, and removing as much tissue as possible would improve survival. Question. What marked the shift in breast cancer treatment approaches in the 1970s? Answer. The NSABP-B04 trial in the 1970s marked a turning point, investigating alternatives to radical mastectomy and paving the way for less extensive surgical procedures. Question. Did radical mastectomy provide a survival advantage over total mastectomy? Answer. Radical mastectomy offered no survival advantage over total mastectomy, which led to the adoption of less aggressive surgery. Question. What have clinical trials shown regarding breast-conserving therapy compared to mastectomy? Answer. 6 prospective clinical trials, including NSABP-B06, demonstrated no survival advantage for mastectomy over breast-conserving therapy. Question. What is the effect of adding radiation therapy to lumpectomy in breast cancer treatment? Answer. Lumpectomy with radiation therapy significantly reduced ipsilateral breast cancer recurrence compared to lumpectomy alone. Question. How do recurrence rates compare between lumpectomy alone and lumpectomy with radiation therapy? Answer. Lumpectomy alone had a recurrence rate of 44.2%, while lumpectomy plus radiation therapy had a significantly lower rate of 8.8%. Question. What did the Luminal A trial reveal about survival and locoregional failure rates in breast cancer surgery? Answer. At 20-year follow-up, no difference in overall survival was observed between radical mastectomy and quadrantectomy with axillary dissection and postoperative irradiation, but locoregional failure rates were higher after quadrantectomy, especially in younger females. Question. Have other randomized trials found any survival benefit for mastectomy over breast-conserving therapy? Answer. 3 additional randomized trials found no survival benefit to mastectomy over breast-conserving therapy in patients with operable breast cancer. Question. How has breast cancer treatment evolved over time? Answer. Breast cancer treatment has shifted from radical mastectomy to breast-conserving surgery and systemic therapy, resulting in improved survival and reduced morbidity. Question. How is the modern approach to breast cancer surgery determined? Answer. The modern approach is tailored to individual patients based on tumor characteristics, patient health, and other risk factors. Question. What is the current conceptual approach in surgical planning for breast cancer? Answer. Surgical planning conceptually separates breast surgery from axillary lymph node surgery. Selection of surgical therapy for the breast. Primary question. What factors are considered when determining suitability for breast conservation therapy? Answer. Patients are evaluated individually based on willingness to undergo radiation therapy and the size of the tumor relative to breast size. Question. What is the role of radiation therapy in breast conserving therapy? Answer. Patients must be willing and able to receive postoperative radiation therapy, and consultation with a radiation oncologist is recommended. Question. When is lumpectomy considered appropriate in breast cancer surgery? Answer. Lumpectomy is considered when the tumor can be excised with clear margins and acceptable cosmetic results, regardless of size. Question. What surgical techniques can be used to improve cosmetic outcomes in breast conservation? Answer. Local tissue rearrangement or pedicled myocutaneous flaps can be used to improve cosmetic outcomes. Question. Are high nuclear grade, lymphovascular invasion, and negative estrogen progesterone receptor status contraindications to breast conservation? Answer. Factors such as high nuclear grade, lymphovascular invasion, and negative estrogen progesterone receptor status are not contraindications to breast conservation if clear margins are achievable. Question. How are multicentric tumors traditionally managed and what do recent studies suggest? Answer. Multicentric tumors are traditionally treated with mastectomy, but recent studies show the safety of breast-conserving therapy with adjuvant radiation for patients with multiple ipsilateral breast cancers. Question. How important is patient preference in surgical decision-making for breast cancer? Answer. Patient preference is central to the decision process between breast-conserving surgery and mastectomy. Question. Is breast-conserving surgery always followed by radiation therapy? Answer. Recent studies have identified subgroups of patients who can undergo breast-conserving surgery without adjuvant radiation. Question. What factors influence the choice between breast-conserving surgery and mastectomy? Answer. Patient preference is considered alongside other factors when deciding between breast-conserving surgery and mastectomy. Breast-conserving surgery technical aspects. Question. What does breast-conserving surgery involve? Answer. Breast-conserving surgery involves removal of the primary tumor with a surrounding rim of normal breast tissue, preserving the rest of the breast. Question. What are the steps involved in the surgical procedure for breast-conserving surgery? Answer. The tumor location is determined, an incision is made, the tumor is excised, the specimen is oriented and inked, and specimen radiography is performed. Question. How are surgical margins managed during breast-conserving surgery? Answer. Intraoperative assessment of margins is performed, with re-excision if needed, and cavity shave margins are taken to reduce positive margins. Margins. Question. What is the standard margin width for invasive breast cancer surgery? Answer. No ink on tumor is the standard for an adequate margin in invasive breast cancer surgery. Question. What is the recommended margin width for ductal carcinoma in situ? Answer. A 2 mm margin is appropriate for ductal carcinoma in situ. Question. What is the impact of positive margins in breast cancer surgery? Answer. Positive margins are associated with a twofold increase in ipsilateral breast tumor recurrence risk. Question. Is a margin wider than 1 mm necessary in breast cancer surgery? Answer. A a 1 mm margin is considered sufficient, and wider margins do not significantly reduce recurrence risk. Question. What is the effect of adjuvant whole breast radiation therapy after surgery? Answer. Adjuvant whole breast radiation therapy decreases the risk of local recurrence in breast cancer patients. Question. What is the role of endocrine therapy for estrogen receptor-positive ductal carcinoma in situ? Answer. Endocrine therapy reduces the risk of local recurrence and the development of new contralateral and ipsilateral breast cancers. Localization of non-palpable breast lesions. Question. What are the drawbacks of traditional wire localization for non-palpable breast lesions? Answer. Traditional wire localization has drawbacks such as pain, vasovagal events, and scheduling issues. Question. What are some alternative methods to wire localization for non-palpable breast lesions? Answer. Radioactive seeds, radar reflectors, radio frequency identification tags, and magnetic seeds offer alternatives to wire localization. Question. What cost-effective localization options are suitable in resource-limited settings? Answer. Intraoperative ultrasound and FIND are suitable for resource-limited settings. Oncoplastic techniques. Question. What is oncoplastic surgery in the context of breast cancer treatment? Answer. Oncoplastic surgery is a surgical approach that prioritizes achieving the best possible aesthetic result while ensuring adequate oncologic margins during breast tumor resection. Question. When is oncoplastic surgery indicated in breast cancer management? Answer. Oncoplastic surgery is recommended for any breast surgery, especially when resecting over 20% of breast tissue, when resection is from an area with poor cosmetic outcome, or when resection may lead to nipple malposition. Question. What factors should be considered when planning oncoplastic surgery? Answer. Factors to consider include the patient's breast size, level of ptosis, tumor size, breast parenchyma type, and tumor location. Question. Who are the best candidates for oncoplastic surgery? Answer. The best candidates are patients with large tumors requiring excision of over 20% of breast volume or those with large orthotic breasts. Question. What oncoplastic surgery techniques are available for breast cancer? Answer. Techniques vary depending on tumor location, size, and breast size or shape, and include Benelli or round block, crescent mastopexy, batwing or hemibetwing, and J or V plasty. Question. What are the benefits of oncoplastic surgery compared to traditional breast-conserving surgery? Answer. Oncoplastic surgery provides greater patient satisfaction, fewer complications, and less local recurrence compared to traditional breast-conserving surgery. Question. When is the preferred timing for oncoplastic reconstruction in breast cancer surgery? Answer. Oncoplastic reconstruction is preferred at the time of tumor resection, so as not to delay adjuvant therapy. Question. Is immediate reconstruction recommended after radiation therapy? Answer. Post-radiation reconstruction is generally not recommended for 1 to 2 years after radiation therapy due to an increased risk of complications. Question. What are the surgical considerations for previously irradiated breasts? Answer. Procedure should be minimized due to impaired healing, and vascularized tissue from outside the radiation field should be used if possible. Mastectomy indications. Question. What are the indications for performing a mastectomy in breast cancer patients? Answer. Indications include large tumors, extensive calcifications, unclear margins after wide local excision, contraindications to breast irradiation, and patient preference. Question. What surgical considerations are there for patients with high-risk genetic mutations and breast cancer? Answer. Patients with high-risk genetic mutations and breast cancer may opt for ipsilateral therapeutic mastectomy and a contralateral prophylactic mastectomy. Technical details. Question. What are the main types of mastectomy and how do they differ? Answer. Simple mastectomy removes the mammary gland, nipple, and areola, while modified radical mastectomy includes axillary lymph node dissection. Question. What incisions are used in mastectomy procedures? Answer. An elliptical incision encompassing the nipple, areola, and previous biopsy scars is used, and skin-sparing mastectomy preserves skin for reconstruction. Question. What is a nipple skin-sparing mastectomy and when is it considered safe? Answer. Nipple skin-sparing mastectomy removes only the nipple areola complex while preserving skin for reconstruction and is considered safe for selected patients. Question. How is breast tissue removed during a mastectomy? Answer. Breast tissue is separated from underlying muscles and axillary contents during mastectomy. Question. What do total, skin-sparing, and nipple-sparing mastectomy involve? Answer. These procedures involve removing breast tissue superficial to the axillary fascia. Question. What does a modified radical mastectomy entail? Answer. Modified radical mastectomy removes level 1 and 2 axillary lymph nodes along with breast tissue. Post-mastectomy breast reconstruction. Question. When can breast reconstruction be performed following mastectomy? Answer. Breast reconstruction can be immediate, meaning on the same day as mastectomy, or delayed, which can be months or years later. Question. What are the advantages of immediate breast reconstruction? Answer. Immediate reconstruction preserves breast skin, combines recovery periods, and avoids a period without a breast mound. Question. What reconstruction options are available after mastectomy? Answer. Options include tissue expanders or implants, and autologous tissue reconstructions such as deep inferior epigastric perforator flap, transverse rectus abdominis myocutaneous flap, or latissimus dorsi flap. Treatment of ductal carcinoma in situ. Question. What percentage of new breast cancer cases does ductal carcinoma in situ represent, and how is it typically detected? Answer. Ductal carcinoma in situ makes up about 20% of new breast cancer cases and is often detected during screening mammograms as clusters of calcifications. Question. How does ductal carcinoma in situ usually appear on a mammogram? Answer. Ductal carcinoma in situ typically shows as clustered, pleomorphic calcifications on mammograms, sometimes accompanied by an area of density, which suggests necrosis and debris inside the ducts. Question. Is ductal carcinoma in situ considered a precursor to invasive ductal carcinoma, and what are the rates of progression? Answer. Ductal carcinoma in situ is considered a precursor to invasive ductal carcinoma, with progression rates ranging from 10% to 64%, depending on factors such as lesion size, grade, and the patient's age. Surgery. Question. What factors determine the basis for treatment of ductal carcinoma in situ? Answer. The basis for treatment includes the extent of the disease, histological grade, estrogen receptor status, presence of microinvasion, as well as the patient's age and personal preference. Question. What are the surgical options for treating ductal carcinoma in situ and what is the surgical goal? Answer. Surgical options include mastectomy, breast-conserving surgery with irradiation, or breast-conserving surgery alone, with the goal of achieving negative margins, meaning no tumor within 2 mm of the ink resection margin. Question: what are the local recurrence and survival rates after breast-conserving treatment and mastectomy for ductal carcinoma in situ? Answer: the local recurrence rate is 1 to 2% per year with breast-conserving therapy and 1 to 2% over a lifetime with mastectomy, with survival rates of 98 to 99% for both approaches. Adjuvant radiation after breast-conserving surgery for ductal carcinoma in situ. Question: how effective is radiation therapy following breast-conserving surgery for ductal carcinoma in situ? Answer: radiation therapy reduces the risk of in-breast recurrence of both ductal carcinoma in situ and invasive cancer by about 50%. Question: what were the findings of the National Surgical Adjuvant Breast and Bowel Project B17 trial regarding radiation therapy for ductal carcinoma in situ? Answer: the addition of radiation to surgery reduced the rate of recurrence in the same breast from 35% to 19.8%. Question: what did the European Organization for Research and Treatment of Cancer 10,853 trial show regarding the use of radiation therapy in ductal carcinoma in situ? Answer: the trial found that radiation reduced the 10-year recurrence rate in the breast from 26% to 15%. Question: what is the overall impact of adjuvant radiation therapy on recurrence rates in patients with ductal carcinoma in situ? Answer: adjuvant radiation therapy significantly lowers the risk of breast recurrence in patients with ductal carcinoma in situ, as demonstrated by several studies. Question: what are the Van Nuys criteria and how successful have they been in identifying ductal carcinoma in situ patients who can avoid radiation therapy? Answer: the Van Nuys criteria were developed to identify ductal carcinoma in situ patients who might not need radiation therapy, but a prospective trial could not replicate its results, showing the difficulty in predicting recurrence risk. Question: what factors are considered when assessing recurrence risk and the need for adjuvant therapy in ductal carcinoma in situ? Answer: factors such as the nuclear grade of ductal carcinoma in situ, lesion size, patient age, and the width of surgical margins are considered when evaluating recurrence risk and the need for additional therapy. Question: when is adjuvant radiation therapy recommended for patients with ductal carcinoma in situ? Answer: adjuvant radiation therapy is recommended for most patients with ductal carcinoma in situ who undergo breast-conserving surgery, to lower the risk of recurrence in the same breast. Question: which subgroup of ductal carcinoma in situ patients may have favorable outcomes without radiation therapy? Answer: patients with small, low-grade, or intermediate-grade ductal carcinoma in situ lesions may have favorable results even without radiation treatment. Question: what is the design and goal of the COMET trial in ductal carcinoma in situ? Answer: the COMET trial is a phase 3 randomized study comparing active surveillance with guideline concordant care, including surgery, radiation, and endocrine therapy, for low-risk ductal carcinoma in situ, with the main goal of measuring the rate of invasive breast cancer in the same breast. Sentinel node dissection in ductal carcinoma in situ. Question: how common are positive sentinel nodes in ductal carcinoma in situ, and what is their significance? Answer: positive sentinel nodes are found in 3.6% of ductal carcinoma in situ cases, likely because of undetected micro-invasive disease. Question: what are the recommendations for performing sentinel node surgery in ductal carcinoma in situ patients? Answer: sentinel node surgery is recommended for patients undergoing mastectomy due to a 20 to 30% chance of finding invasive cancer, and it is considered for patients having breast-conserving surgery with higher risk features such as larger areas of ductal carcinoma in situ, the presence of a palpable mass, or high-grade histology. Question: what is the Sentinel trial and how does it change the approach to sentinel lymph node dissection in ductal carcinoma in situ? Answer: the Sentinel trial involves injecting supraparamagnetic iron oxide during surgery, which allows for delayed sentinel lymph node dissection if invasive disease is later found in the final pathology, potentially reducing the need for immediate sentinel lymph node dissection in a significant number of patients. Adjuvant systemic therapy in ductal carcinoma in situ. Question: is systemic chemotherapy needed for ductal carcinoma in situ without evidence of invasion, and why? Answer: systemic chemotherapy is not needed for ductal carcinoma in situ without evidence of invasion because there is a low risk of lymphatic spread or metastatic disease. Question: when is hormonal therapy considered for patients with ductal carcinoma in situ? Answer: hormonal therapy may be used to prevent new primary tumors and improve local control after breast-conserving treatment, especially in patients with estrogen receptor-positive ductal carcinoma in situ. Question: what benefits does tamoxifen provide for patients with estrogen receptor-positive ductal carcinoma in situ? Answer: tamoxifen decreases the risk of both recurrence in the same breast and in the opposite breast in patients with estrogen receptor-positive ductal carcinoma in situ, particularly in those at high risk for local recurrence. Question: how effective is adjuvant endocrine therapy in reducing breast cancer recurrence in ductal carcinoma in situ patients? Answer: adjuvant endocrine therapy can reduce the risk of breast cancer recurrence in ductal carcinoma in situ patients by about 50%. Question: what factors influence the decision to use endocrine therapy in ductal carcinoma in situ? Answer: the decision to use endocrine therapy depends on the type of surgery performed, the treatment goals, the patient's age and other medical conditions, the characteristics of the ductal carcinoma in situ, and the side effect profile of the therapy. Question: how does anastrozole compare to tamoxifen for postmenopausal patients with ductal carcinoma in situ, according to the National Surgical Adjuvant Breast and Bowel Project B35 trial? Answer: anastrozole was found to be superior to tamoxifen in improving breast cancer-free survival among postmenopausal patients younger than 60 years old in the National Surgical Adjuvant Breast and Bowel Project B35 trial. Radiation therapy for breast cancer. Question: what is the purpose of adjuvant radiation therapy for breast cancer patients after surgery? Answer: adjuvant radiation therapy is given to breast cancer patients after surgery to improve local regional control and reduce mortality. Question: what areas are targeted in adjuvant radiation therapy regimens for breast cancer, and how are these determined? Answer: adjuvant radiation therapy regimens include radiation to the breast, nodal basins, or chest wall, depending on the patient's risk factors and surgical procedure. Question: what approaches have been explored to reduce the morbidity associated with radiation therapy in breast cancer? Answer: efforts to reduce radiation morbidity include exploring alternatives like hypofractionation, partial breast irradiation, and identifying patients who may not need adjuvant radiation therapy. Radiation therapy after breast breast-conserving surgery. Question: what are the benefits of adjuvant radiation therapy for patients with invasive breast cancer treated with breast-conserving surgery? Answer: adjuvant radiation therapy reduces breast recurrence and improves survival in invasive breast cancer patients treated with breast-conserving surgery. Question: how does adjuvant radiation therapy impact recurrence and mortality rates in breast cancer patients? Answer: adjuvant radiation therapy significantly lowers local and distant recurrence rates and breast cancer-related deaths, particularly in node-positive patients. Question: are there patient subgroups who may safely avoid radiation therapy after breast-conserving surgery? Answer: patients over 70 years old with stage I estrogen receptor-positive breast cancer who receive hormonal therapy may be able to safely avoid radiation therapy. Question: what effect does postoperative radiotherapy have on elderly patients with hormone receptor-positive breast cancer? Answer: postoperative radiotherapy improves local control but does not significantly impact overall survival or recurrence rates in hormone receptor-positive breast cancer patients over 65 years old. Question: what is the preferred schedule for whole breast irradiation, and why? Answer: hypofractionated whole breast irradiation, 42.5 gray and 16 fractions over 22 days, is preferred over the historical 5-8-week schedule due to equivalent local recurrence rates and cosmetic outcomes. Question: what is partial breast irradiation, and how is it administered? Answer: partial breast irradiation is an approach to reduce radiation burden by focusing on the tumor bed area, potentially using brachytherapy, balloon catheters, intraoperative radiation, or external beam radiation. Question: which study populations have been included in research comparing radiation therapy modalities for breast cancer? Answer: patients with early-stage breast cancer, including ductal carcinoma in situ, stage I, and stage II disease, have been included in such studies. Question: what treatment modalities are compared in studies involving accelerated partial breast irradiation and whole breast irradiation? Answer: studies compare accelerated partial breast irradiation before adjuvant chemotherapy and whole breast irradiation after adjuvant chemotherapy. Question: what outcomes have been observed when comparing partial breast irradiation and whole breast irradiation? Answer: no significant differences in distant disease-free survival, overall survival, or disease-free survival between the two groups have been observed, but the 10-year cumulative incidence of ipsilateral breast tumor recurrence was slightly higher in the partial breast irradiation group. Post-mastectomy radiation therapy. Question: what are the benefits of post-mastectomy radiation therapy for patients with stage 3 breast cancer? Answer: post-mastectomy radiation therapy significantly improves outcomes for patients with stage 3 breast cancer, reducing locoregional recurrence rates and improving overall survival. Question: how effective is post-mastectomy radiation therapy in reducing recurrence and mortality rates? Answer: post-mastectomy radiation therapy reduces the 5-year isolated locoregional recurrence rate from 23% to 6% and the 15-year breast cancer mortality rate from 60.1% to 54.7%. Question: is post-mastectomy radiation therapy required for patients with T1N0 or T2N0 breast cancer? Answer: post-mastectomy radiation therapy is not required for patients with T1N0 or T2N0 breast cancer, as mastectomy and sentinel lymph node dissection provide effective local control. Question: for which patients is post-mastectomy radiation therapy recommended? Answer: post-mastectomy radiation therapy is recommended for patients with 4 or more positive lymph nodes or other stage 3 disease characteristics. Question: is post-mastectomy radiation therapy indicated for stage 2 breast cancer patients? Answer: the use of post-mastectomy radiation therapy for stage 2 patients is controversial due to low locoregional recurrence rates after standard treatment, but it may be considered for selected patients with specific risk factors. Question: what is being investigated regarding the de-escalation of treatment in breast cancer patients following neoadjuvant therapy? Answer: ongoing investigations are exploring the possibility of reducing treatment intensity based on response to neoadjuvant therapy, including potentially omitting regional nodal irradiation or axillary surgery in certain cases. Systemic therapy for breast cancer. Question: what is the prognosis for patients with metastatic breast cancer? Answer: metastatic breast cancer is the primary cause of death, often occurring within 5 to 10 years of diagnosis despite locoregional therapy. Question: what is the role of systemic therapy in breast cancer treatment? Answer: systemic therapy is used to treat and prevent recurrence in resectable disease and to manage symptoms and potentially prolong survival in stage 4 breast cancer. Question: when does metastasis likely occur in breast cancer progression, and how does this affect the use of systemic therapy? Answer: metastasis likely occurs early in breast cancer progression, supporting the use of systemic therapy alongside local treatment, although accurate detection of occult metastatic disease remains a challenge. Goals of therapy and assessment of potential benefits and risks from therapy. Question: what is the treatment goal for patients with stage 1 to 3 invasive breast cancer? Answer: the treatment goal is cure for stage 1 to 3 invasive breast cancer patients. Question: how should treatment selection be approached in breast cancer therapy? Answer: treatment selection should weigh potential benefits, such as recurrence risk reduction, against potential harms, considering patient preferences, especially regarding adjuvant therapy. Question: what factors influence recurrence risk and guide treatment decisions in breast cancer? Answer: disease stage, tumor biology including estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2 status, as well as multi-gene assays like Oncotype DX, influence recurrence risk and guide treatment decisions. Question: in which patients has the Oncotype DX assay been validated, and what does it predict? Answer: the Oncotype DX assay has been validated in patients with estrogen receptor positive, lymph node negative breast cancer, predicting benefits of systemic therapy. Question: how does the Oncotype DX assay assist clinicians in managing breast cancer? Answer: the Oncotype DX assay helps clinicians estimate the benefits of therapy for patients with estrogen receptor positive breast cancer and 0 to 3 positive lymph nodes. Question: what were the results of the TAILORx trial regarding endocrine therapy and chemotherapy? Answer: endocrine therapy alone was non-inferior to chemotherapy followed by endocrine endocrine therapy in patients with intermediate recurrence scores, except for some benefit in females 50 years of age or younger with a recurrence score of 16 to 25. Question: what was the objective of the trial involving chemotherapy benefits for patients with 1 to 3 positive nodes and a low intermediate recurrence score? Answer: the objective was to determine the benefit of chemotherapy in patients with 1 to 3 positive nodes and a low intermediate recurrence score. Question: how was the trial designed for patients with hormone receptor positive and human epidermal growth factor receptor 2 negative breast cancer? Answer: 5,018 patients with hormone receptor positive and human epidermal growth factor receptor 2 negative breast cancer, 1 to 3 positive axillary nodes, and a recurrence score of 25 or lower were randomized to chemotherapy followed by endocrine therapy or endocrine therapy alone. Question: what were the trial results regarding chemotherapy benefit for postmenopausal and premenopausal females? Answer: postmenopausal patients did not benefit from chemotherapy, while premenopausal females showed a 5-year invasive disease-free survival benefit from chemotherapy followed by endocrine therapy. Chemotherapy question: what are the main classes of chemotherapeutics used for early-stage breast cancer? Answer: anthracyclines and taxanes are the main classes used for early-stage breast cancer. Question: what are the risks associated with anthracycline chemotherapy? Answer: anthracyclines are effective but carry risks of cardiomyopathy and leukemia. Question: what is the significance of taxanes in metastatic breast cancer? Answer: taxanes show significant activity in metastatic breast cancer and improve disease-free survival and overall survival. Question: how do docetaxel and paclitaxel compare in efficacy, and what are their side effects? Answer: docetaxel and paclitaxel are equivalent in efficacy, administered every 3 weeks, and may cause peripheral neuropathy. Question: why is chemotherapy typically given in combinations? Answer: chemotherapy is typically given in combinations to maximize effectiveness and minimize side effects. Question: what are the benefits of polychemotherapy in breast cancer treatment? Answer: analysis of randomized trial shows that cyclophosphamide, methotrexate, and fluorouracil or standard doxorubicin and cyclophosphamide reduces recurrence rate by 1/3 at 8 years and mortality by 20 to 25%, while cyclophosphamide, doxorubicin, and fluorouracil or cyclophosphamide, epirubicin, and fluorouracil provides an additional 15 to 20% reduction in mortality compared to cyclophosphamide, methotrexate, and fluorouracil or doxorubicin and cyclophosphamide. Question: how effective are taxane and anthracycline regimens in reducing breast cancer mortality? Answer: taxane or anthracycline regimens, regardless of age or tumor characteristics, reduce breast cancer mortality by approximately 1/3. Question: when can docetaxel and cyclophosphamide-based adjuvant therapy replace anthracycline-containing regimens? Answer: docetaxel and cyclophosphamide-based adjuvant therapy can safely replace anthracycline-containing regimens in many early human epidermal growth factor receptor 2 negative breast cancer patients. Question: how do taxane-based and anthracycline-based regimens compare in terms of risk reduction for breast cancer mortality? Answer: taxane-based and anthracycline-based regimens show similar proportional risk reductions for breast cancer mortality. Human epidermal growth factor receptor 2-based targeted therapy question: how common is human epidermal growth factor receptor 2 gene amplification or protein overexpression in breast cancers? Answer: human epidermal growth factor receptor 2 gene amplification or protein overexpression occurs in 20 to 25% of breast cancers. Question: what is trastuzumab and how is it used in breast cancer treatment? Answer: trastuzumab is a humanized monoclonal antibody that targets the human epidermal growth factor receptor 2 receptor and is effective in treating metastatic breast cancer, especially when combined with chemotherapy. Question: what are the benefits of 1 year of adjuvant trastuzumab therapy for human epidermal growth factor receptor 2 positive breast cancer patients? Answer: 1 year of adjuvant trastuzumab treatment significantly reduces the risk of breast cancer recurrence and improves overall survival in human epidermal growth factor receptor 2 positive breast cancer patients. Question: what risk is associated with trastuzumab-based therapy? Answer: patients receiving trastuzumab-based therapy, especially those with pre-existing heart conditions, are at an increased risk of cardiac dysfunction. Question: how do ACTH and TCH regimens compare in disease-free survival and cardiac toxicity? Answer: both ACTH and TCH regimens demonstrate superior disease-free survival compared to controlled treatments, with TCH showing lower cardiac toxicity rates. Question: what is the effect of adding pertuzumab to trastuzumab-based therapy in human epidermal growth factor receptor 2 positive breast cancer? Answer: the addition of pertuzumab to trastuzumab-based therapy significantly improves disease-free survival in patients with node-positive or high-risk node-negative breast cancer. Question: what is the standard of care for human epidermal growth factor receptor 2 positive breast cancer? Answer: trastuzumab and pertuzumab with chemotherapy in the neoadjuvant setting is the standard of care for patients with human epidermal growth factor receptor 2 positive tumors that are 2 centimeters or larger or with positive nodal disease. Question: what is the recommended treatment for smaller human epidermal growth factor receptor 2 positive breast tumors? Answer: surgery, with chemotherapy and trastuzumab, with or without pertuzumab, is recommended in the adjuvant setting based on final pathology. Question: how is adjuvant treatment determined based on pathologic complete response in human epidermal growth factor receptor 2 positive breast cancer? Answer: patients who experience a pathologic complete response would generally continue adjuvant trastuzumab with or without pertuzumab for a year, while those who do not experience a pathologic complete response have an indication for adjuvant ado. Trastuzumab emtansine for 14 cycles. Question: which additional drugs targeting human epidermal growth factor receptor 2 are being evaluated, and with what combinations? Answer: additional drugs targeting human epidermal growth factor receptor 2, including tyrosine kinase inhibitors like lapatinib, neratinib, pirotinib, and tucatinib, are being evaluated in combination with trastuzumab. Question. What benefits does neratinib offer after adjuvant treatment with trastuzumab? Answer. Neratinib, after adjuvant treatment with trastuzumab, has been shown to improve recurrence-free survival, particularly in patients with human epidermal growth factor receptor 2 positive and hormone receptor positive tumors or high-risk larger tumors. Question. What is the effect of adding lapatinib to trastuzumab in the neoadjuvant setting? Answer. Adding lapatinib to trastuzumab in the neoadjuvant setting has been shown to improve pathologic complete response and potentially improve recurrence-free survival and overall survival. Endocrine therapy. Question. What is the therapeutic approach of oophorectomy in breast cancer? Answer. Oophorectomy is used to reduce systemic estrogen production. Question. Which breast cancers are targeted by endocrine therapy? Answer. Endocrine therapy targets breast cancers expressing estrogen receptor or progesterone receptor. Question. What are the benefits of endocrine therapy for females with metastatic breast cancer? Answer. Endocrine therapy improves disease-free survival and overall survival for females with metastatic breast cancer, with a generally favorable adverse effect profile. Tamoxifen. Question. What is the mechanism of action of tamoxifen? Answer. Tamoxifen is a selective estrogen receptor modulator with antagonistic and weak agonistic effects. Question. What are the side effects associated with tamoxifen therapy? Answer. Hot flashes are common, while thromboembolic events, uterine cancer, and cataracts are rare but serious. Question. How effective is tamoxifen in reducing breast cancer recurrence and mortality? Answer. Tamoxifen reduces breast cancer recurrence and mortality, with 5 years of therapy showing significant benefits and 10 years providing even greater long-term advantages. Question. How does the duration of tamoxifen treatment affect breast cancer outcomes? Answer. Longer duration, such as 10 years, showed decreased breast cancer recurrence and mortality rates compared to 5 years. Question. What are the ASCO guidelines for tamoxifen therapy in premenopausal and perimenopausal females? Answer. For premenopausal or perimenopausal females, 5 years of tamoxifen is recommended, followed by an additional 5 years if still premenopausal or an aromatase inhibitor if postmenopausal. Aromatase inhibitors. Question. What is the mechanism of action of aromatase inhibitors? Answer. Aromatase inhibitors block the conversion of androstenedione into estrogen, reducing estrogen levels in the body. Question. How do selective aromatase inhibitors differ from earlier generations? Answer. Selective aromatase inhibitors purely block the final step of estrogen conversion, minimizing side effects compared to earlier generations. Question. What is the efficacy of aromatase inhibitors in adjuvant therapy for breast cancer? Answer. Aromatase inhibitors have been shown to improve disease-free survival and reduce the risk of distant recurrence and contralateral breast cancers compared to tamoxifen. Question. For which patients is extended aromatase inhibitor therapy recommended? Answer. Extended aromatase inhibitor therapy for up to 10 years is recommended for postmenopausal patients with node-positive, hormone receptor-positive breast cancer. Question. When can extended aromatase inhibitor therapy be considered for node-negative patients? Answer. Extended aromatase inhibitor therapy can be considered for node-negative patients based on risk factors, but it is not recommended for low-risk node-negative patients. Question. How does the use of aromatase inhibitors after 2 to 3 years of tamoxifen treatment affect cancer outcomes? Answer. Using aromatase inhibitors after 2 to 3 years of tamoxifen treatment is associated with better cancer outcomes than tamoxifen alone. Ovarian ablation. Question. What are the benefits of ovarian ablation or suppression for premenopausal females with breast cancer? Answer. Ovarian ablation or suppression reduces relapse and death from breast cancer in premenopausal females. Question. How does ovarian ablation compare to cyclophosphamide, methotrexate, and fluorouracil chemotherapy in premenopausal females with lymph node positive, stage 2 breast cancer? Answer. Ovarian ablation showed equivalent outcomes in terms of disease-free survival and overall survival in premenopausal females with lymph node positive, stage 2 breast cancer. Question. When is ovarian suppression with endocrine therapy recommended in breast cancer treatment? Answer. Ovarian suppression with endocrine therapy is recommended for hormone receptor positive high-risk breast cancer patients, particularly those receiving systemic chemotherapy, to improve disease-free survival and overall survival. Additional systemic therapy options. Question. What is the effect of CDK4/6 inhibitors in metastatic breast cancer? Answer. Palbociclib, abemaciclib, and ribociclib improve progression-free survival and overall survival in metastatic breast cancer. Question. What is the impact of CDK4/6 inhibitors in adjuvant breast cancer treatment? Answer. Abemaciclib improves disease-free survival and recurrence-free survival in high-risk hormone receptor positive and human epidermal growth factor receptor 2 negative breast cancer, while palbociclib showed no benefit. Question. What is the role of immunotherapy in triple-negative breast cancer? Answer. Pembrolizumab and atezolizumab, when added to chemotherapy, increase pathologic complete response rates in neoadjuvant triple-negative breast cancer. Question. For which patients is PARP inhibitor olaparib indicated in the adjuvant setting? Answer. PARP inhibitor olaparib is indicated for patients with human epidermal growth factor receptor 2 negative disease and a BRCA1 or BRCA2 mutation in the adjuvant setting. Question. What efficacy has olaparib shown in breast cancer clinical trials? Answer. Olaparib has been shown to improve 4-year invasive disease-free survival, overall survival, and distant disease-free survival in the Olympia trial. Question. What ongoing research is being conducted with olaparib and other agents? Answer. Trials are ongoing with combinations of olaparib and other agents like phosphatidylinositol 3 kinase, AKT, mammalian target of rapamycin inhibitors, CDK4/6 inhibitors, anti-programmed cell death ligand 1 antibodies, endocrine therapy, and newer anti-human epidermal growth factor receptor 2 agents. Neoadjuvant systemic therapy for operable breast cancer. Question. What are the advantages of neoadjuvant therapy for operable breast cancer? Answer. Neoadjuvant therapy has the potential to lower microscopic metastatic disease, decrease drug resistance, increase treatment efficacy, reduce tumor size, and evaluate treatment response. Question. How does response to neoadjuvant chemotherapy correlate with survival outcomes? Answer. Response to neoadjuvant chemotherapy correlates with survival outcomes, particularly in patients with aggressive tumor subtypes. Question: what practical benefits does neoadjuvant therapy provide in breast cancer treatment? Answer: neoadjuvant therapy allows for surgical de-escalation and tailoring of adjuvant therapy based on tumor response. Question: how does neoadjuvant therapy affect breast conservation rates and cosmetic outcomes? Answer: neoadjuvant therapy increases breast conservation rates and may shrink tumors for improved cosmetic outcomes. Question: what is the efficacy of neoadjuvant therapy compared to adjuvant therapy? Answer: neoadjuvant therapy offers no survival advantage or detriment compared to adjuvant therapy, but results in higher breast conservation rates. Question: why is metallic clip placement in the tumor site important before neoadjuvant therapy? Answer: metallic clip placement in the tumor site before neoadjuvant therapy helps identify the original tumor site for excision after therapy. Question: how accurate is sentinel lymph node dissection after neoadjuvant chemotherapy? Answer: sentinel lymph node dissection is feasible and accurate after neoadjuvant chemotherapy, with sentinel node identification rates of 91 to 96% and false negative rates of 6 to 10.5%. Question: what is the necessity of axillary lymph node dissection after neoadjuvant treatment? Answer: the necessity of axillary lymph node dissection is questioned due to increasing pathological complete response rates in node-positive patients after neoadjuvant treatment. Question: how does the neoadjuvant approach help inform adjuvant treatment choices? Answer: the neoadjuvant approach allows for learning about tumor biology and response to treatment, which can inform adjuvant treatment choices. Question: why is accurate tumor burden assessment important in breast cancer treatment? Answer: accurate tumor burden assessment is crucial for defining prognosis and determining personalized adjuvant therapy, especially with the introduction of new targeted regimens. Question: what are the potential disadvantages of neoadjuvant chemotherapy in breast cancer? Answer: neoadjuvant chemotherapy may result in loss of pre-chemotherapy prognostic information, such as axillary lymph node status and actual invasive tumor size, which may impact post-mastectomy radiation therapy decisions. Treatment of special conditions: locally advanced and inflammatory breast cancer. Question: how is locally advanced breast cancer defined? Answer: locally advanced breast cancer is defined as breast cancer occurring in patients who have large primary tumors, involvement of the chest wall, skin involvement, or clinically apparent lymph node involvement, corresponding to stages 2B, 3A, 3B, and 3C. Question: what is the main treatment goal for patients with locally advanced breast cancer and no evidence of distant metastasis? Answer: the main treatment goal is to address the risk of both local and systemic relapse in these patients. Question: what are the characteristics of inflammatory breast cancer? Answer: inflammatory breast cancer is a rare but aggressive subtype of breast cancer characterized by diffuse tumor involvement of the lymphatic channels, which manifests as redness, swelling, and warmth of the breast. Question: how is inflammatory breast cancer diagnosed? Answer: inflammatory breast cancer is diagnosed clinically, based on the presence of tumor cells within the dermal lymphatics, although this may often be missed because of sampling error. Question: what is the recommended treatment for inflammatory breast cancer? Answer: the recommended treatment for inflammatory breast cancer is a combined modality approach, which includes neoadjuvant chemotherapy, modified radical mastectomy without immediate reconstruction, and post-mastectomy radiation therapy, along with appropriate adjuvant systemic therapy. Question: what is the prognosis for inflammatory breast cancer following trimodal treatment? Answer: the prognosis for inflammatory breast cancer following trimodal treatment includes locoregional recurrence rates as low as 6.9%, with a distant recurrence rate of 35.1% during a 5-year median follow-up period. Breast cancer in older adults. Question: what surgical options are available for older females with small, hormone receptor-positive breast cancer? Answer: studies suggest that lumpectomy without radiation is a viable surgical option for older females with small, hormone receptor-positive breast cancer. Question: what are the recommendations regarding sentinel lymph node biopsy in older females with early-stage, hormone receptor-positive breast cancer? Answer: the Society of Surgical Oncology recommends avoiding routine sentinel lymph node biopsy in clinically node-negative females 70 years or older with early-stage hormone receptor-positive breast cancer, as long as they are receiving adjuvant endocrine therapy. Question: how does adjuvant endocrine therapy impact survival outcomes in older females with hormone receptor-positive breast cancer? Answer: adjuvant endocrine therapy significantly improves survival outcomes in older females with hormone receptor-positive breast cancer and may reduce the need for extensive surgery and radiation. Paget disease. Question: what is Paget disease of the breast? Answer: Paget disease of the breast is a rare type of breast cancer characterized by changes in the nipple, often associated with an underlying breast carcinoma. Question: how is Paget disease of the breast diagnosed? Answer: the diagnosis of Paget disease of the breast is confirmed by a biopsy of the nipple skin, which reveals the presence of Paget cells. Question: what are the treatment options for Paget disease of the breast? Answer: treatment options for Paget disease of the breast include mastectomy with axillary staging, or wide local excision with clear margins, axillary staging, and adjuvant radiation therapy. Breast cancer in males. Question: how common is breast cancer in males? Answer: less than 1% of new breast cancer cases and deaths occur in males. Question: what are the risk factors for breast cancer in males? Answer: risk factors for breast cancer in males include increasing age, radiation exposure, and conditions related to abnormal hormone balance. Question: what are the typical symptoms and how is breast cancer diagnosed in males? Answer: symptoms of breast cancer in males include a breast mass, involvement of the nipple, and other symptoms, and diagnosis involves imaging and biopsy. Question: what are the treatment options for small tumors in males with breast cancer? Answer: treatment options for small tumors in males with breast cancer include local excision with irradiation or mastectomy. Question: what is the recommended treatment for males with pectoral muscle involvement? Answer: the recommended treatment for males with pectoral muscle involvement is modified radical mastectomy with excision of the involved portion of the muscle, and possibly postoperative radiation therapy. Question: what adjuvant therapies are considered for males with breast cancer based on hormone receptor status and node involvement? Answer: chemotherapy, targeted therapy, and endocrine therapy such as tamoxifen tamoxifen or gonadotropin-releasing hormone agonists or antagonists with an aromatase inhibitor are considered, depending on hormone receptor status and lymph node involvement. Breast cancer during pregnancy question. How frequently is breast cancer diagnosed during pregnancy? Answer. Breast cancer is diagnosed in approximately 1 out of every 3,000 to 10,000 pregnancies. Question. What are the treatment options for breast cancer during pregnancy? Answer. Treatment options for breast cancer during pregnancy are similar to those for non-pregnant patients, but with the consideration to avoid irradiation, endocrine therapy, HER2-directed therapy, and certain chemotherapeutic agents during pregnancy. Question. Is it safe to temporarily interrupt adjuvant endocrine therapy to attempt pregnancy in hormone receptor-positive breast cancer patients? Answer. Yes. Trial results indicate that temporary interruption of adjuvant endocrine therapy to attempt pregnancy is safe for hormone receptor-positive breast cancer patients. That's it. Thanks for tuning in. If you enjoy our content, please like, share, and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.